my privilege to introduce our distinguished panelists. We have with us today Kathleen Sebelius, former Secretary, U.S. Department of Health and Human Services and CEO of Sebelius Resources, LLC. We have Dr. Lori Hicks, Chief Medical Officer, COVID-19 Response Team, Center for Disease Control. Dr. Mark McClellan, former FDA Commissioner and Director of the Duke Robert J. Margolius Center for Health Policy. And Dr. Albert Coe, Department Chair, and Rajan Indranui, Professor of Public Health and Professor of Epidemiology and of Medicine, Yale School of Public Health and Yale School of Medicine. I want to first turn to Dr. Hicks. Dr. Hicks, can you explain to us and help us understand the President's announcement yesterday, where he charged the Department of Labor to require the vaccination among all employees of firms with 100 or more employees, or get tested weekly? He noted that this would include 80 to 100 million employees. Can you help us understand that decision and the science and the data on the Delta variant that underlies it?
Well, first of all, thank you so much for inviting me to be a part of this panel. It's quite an honor. And I do have to say that I apologize if you hear some barking in the background. My dogs have some strong opinions on this topic. So I will start by mentioning that that President Biden's announcement yesterday really comes at a time when we're seeing an alarming increase in cases and deaths. And I just wanted to put that into perspective for all of you. In late June, the average daily reported number of cases was around 12,000. On July 27th, the daily average of cases reached over 60,000, and the current average is over 150,000 cases per day. So this has coincided with an increase in deaths. We're now averaging over 1,000 deaths per day. The increase in cases that we've experienced really coincides with the spread of Delta, which now represents 99% of the laboratory tested specimens that we're seeing here in the United States. So it's absolutely appropriate that aggressive action be taken because the Delta variant is highly contagious. We know that it's more than 2 times as contagious as the previous variants, and the greatest risk of transmission among our population is among unvaccinated people, who are much more likely to get infected and transmit the virus. We know that fully vaccinated people can still get COVID-19, and this is known as a breakthrough infection. And this is why we need everyone engaged in preventing spread. So our COVID-19 vaccines are working really well. They offer substantial protection against hospitalization and death from the Delta variant. The vast majority of hospitalization and deaths are caused by COVID-19 in unvaccinated people. And I think that's the key here. Unvaccinated people are the ones that we're seeing in our emergency departments, in our hospitals. The risk is about 30 times higher compared to vaccinated persons in terms of hospitalization. Our data are suggesting that while vaccinated people are much less likely than unvaccinated people to become infected with COVID-19, there is lower vaccine effectiveness against laboratory confirmed illness and symptomatic disease due to Delta. So that is where this is a little bit different than the other variants that we've seen. So hence the need to intensify our prevention efforts. Vaccination remains the best way to protect yourself, your family, and your community. And we're recommending that everyone aged 12 years and older get vaccinated as soon as possible. And given what we know about the Delta variant, the vaccine effectiveness and current vaccine coverage, layered prevention strategies are needed, including wearing masks, were needed to reduce the transmission of the variant. So as we build the level of vaccination nationwide, we must leverage all the prevention strategies available, all the tools in our toolbox, including masking indoors in public places to stop transmission. Physical distancing is important, improving ventilation. And here's the key. This will go a long way to keeping our schools open, our businesses open, and our children safe and hopefully our dog's safe too.
Dr. Hicks, thank you. Thank you for that underlying data, which is really important. Particularly, there's been a lot of confusion about vaccine efficacy. And Secretary Sebelius, turning to you in terms of trying to understand yesterday's announcement, the president said he had the authority to mandate the shots for healthcare workers and to mandate that all companies with more than 100 employees require vaccinations or testing. Where can you explain where the authority comes from in a little bit more detail?
Sure. I think I joined Dr. Hicks in thanking you for bringing us all together and having this really critical conversation at an enormously important time. And Dr. Hicks just laid out the groundwork. We are at a very dangerous time in the Delta spread. And what's at risk is, once again, our kids in school and the economy writ large. So the president is doing, I think, what every president is charged with doing, is putting the health and safety of the constituents of the United States of America as his front and center goal. So he's first using all of the authority as a federal employer with regard to those employees who come to work for the federal government and putting the vaccine mandates in place for them and for contractors. Then he turned to healthcare workers who, by way of receiving Medicaid and Medicare funding, which is a large portion of the funding that goes to particularly hospitals, goes to nursing homes, and Medicaid is the largest payer of nursing homes, is saying, if you rely on federal money, you need to put a vaccine mandate in place for your employees. Again, dealing with some of the most vulnerable people in the United States, we want those employees to be vaccinated in nursing homes and in hospitals and in residential care centers. And finally, he turned to the private sector. Many of the private sector employers have stepped up, but he's asking OSHA, which is the Occupational Health and Safety Agency under the Department of Labor, to put in place a standard of workplace safety, which is what OSHA is charged with doing for companies over 100, and saying part of workplace safety is if you're bringing people back into the workplace, then you need a vaccine mandate or a testing protocol in place to make sure that workers are safe. It's one thing to order your workers to come back and be in the office or be in the factory or be on the meat processing line. But you have a responsibility, employer, to keep those employees safe and secure. So it is really the OSHA recommendation that will be the rule that will be in place for the private employers. I would say that presidents, starting with George Washington in the days of smallpox, have used mandates to try and stem deadly diseases from spreading. And I think that President Biden had hoped that encouraging people, having free vaccines available widely in the country, mobilizing a lot of public support, not only from the scientific community, but people's doctors and rock stars and athletic stars and getting coaches involved, and others would have continued to spur the American public to get vaccinated. But we still have a chunk of folks who have decided for one reason or another that they will not take up the vaccine. And by doing that, by making that choice, are putting at risk, the millions of children who are under the age of 12, including my 4 grandchildren who are 9 and down, who cannot be vaccinated, as well as lots and lots of people who are vaccinated but may have a breakthrough infection. So I think he is now turning to mandatory rules to keep the American public safe and secure, and most importantly, keeping our kids in school and keeping the economy running.
If we could just step back a little, Secretary Sebelius, there's also a lot of confusion about how the decision-making process works. And the CDC and the Food and Drug Administration, they're part of HHS's family of agencies. And as a former secretary, can you help us understand how these decisions are made, what role the agencies play, HHS plays, and how it interacts with the White House?
Well, HHS is the Department of Health and Human Services is a large umbrella agency. It's one of the biggest domestic agencies in the government, and there are 11 operating divisions under the umbrella of Health and Human Services. Well known are the Food and Drug Administration, the Centers for Disease Control and Prevention, the National Institutes of Health, also CMS, the big payer of public health programs, Medicare and Medicaid. There's aging, there's children and families, which includes now the refugee resettlement. So it's a sprawling agency that really touches a lot of people from birth to death, if you will. They have some connection with HHS. The agencies that are primarily considered, quasi-independent, if you will, are the Food and Drug Administration, where there's interaction with the central office, but the Food and Drug Administration works on rules to approve and regulate drugs and cosmetics, and about 25 cents of every consumer dollar is a product that goes through the Food and Drug Administration, food safety, and they really operate based on the scientific evidence that's brought forward. Centers for Disease Control and Prevention is another quasi-independent agency. The biggest interaction that CDC has is both with state health departments, where there are employees throughout this country, the backbone of public health and epidemiology and collecting data, but also there are CDC employees working around the world. We have employees in about 50 countries around the world, and a lot of interaction based on, again, scientific evidence. And it is really the public health gold standard in the world. People want to replicate the CDC in countries. There's a lot of collaborative, cooperating work going on. So the HHS central office doesn't make decisions for these independent agencies. They don't try to overrule the science. There's discussion about timing and interface. And I think all of us used to report to the President of the United States. I came to the Secretary's office as a governor. I hadn't had a boss in a long time, and I would make decisions in our conference room and say, okay, we're going to do this. And somebody would say to me, Secretary, we're going to talk to the President about doing that. And it's like, oh yeah, there's that guy down the street, and he really, he's the chief executive. So while HHS is a significant agency and has decision-making authority, but President Obama in my day, and now President Biden, who worked closely with President Obama during that administration, is a believer that they will be led by the science. They will follow the science. They will not have politics overrule the science. And that is, I think, an abiding belief that both of these presidents shared and really put forward, that even if there's certainly going to be discussion about timing and about how fast things can go and couldn't things hurry up and what do you know and when are we going to know it, but that the science will take the lead in both the FDA and the CDC, and they will not interfere, even if that's politically inconvenient. They want to be directed in a public health crisis by the scientists.
So turning to Dr. McClellan as a former FDA commissioner on when will we know it, the president had obviously the third booster shot is a critical decision in all of our major decision in our effort to defeat the pandemic. And the president said yesterday he would follow the FDA timelines on the boosters. And can you, the FDA recently put the brakes on that rollout. Can you take us inside the FDA and hopefully shed some light on what you think the timelines on that decision will be and what actually goes into the consideration of that decision?
Yeah, Lori, thanks first to you and CED for bringing this discussion together, and some lively comments and questions in the chat that I hope we can get to as well. So there are two constraints that the administration is trying to operate within. On the one hand, they want to make boosters available as soon as the scientific evidence permits. And frankly, there are well over 1 million Americans who have gone ahead and gotten the third booster already, not waiting for that evidence to come in. The the reason that the administration is talking about a date around September 20th is that that comes right after an FDA advisory committee meeting and then presumably some follow-up action by the CDC, which you heard about from Secretary Sebelius, to make recommendations on the safety and effectiveness of a booster dose and on how it should be used. That's going to happen first for the Pfizer vaccine. Pfizer has already submitted all of the data that FDA has asked for on large numbers of people getting the boosters to get a very good idea about the safety and about the effectiveness of the booster dose. The early data that's been published and that we've seen suggests that the boosters do lead to a big increase in the antibody production and maybe some impacts on other key parts of the immune response. We know from other vaccines that giving people an exposure early, 1 or 2 doses within a couple of months for the childhood vaccines and another dose significantly later. It's like your body gets exposed to the infection twice and creates a more lasting and effective response. So we think that's probably going to happen here, but it's really important to know for sure. I know there are a lot of questions and comments in the chat about what is the evidence, and that's what the administration's trying to balance, to move as quickly as possible, but to not get ahead of the science. So what I would expect is that by the time the FDA has this public meeting, which is a week from today, there will be a lot more out there about what the booster evidence shows for the Pfizer vaccine and what a number of FDA's independent expert advisors think about all of that. And then that's going to inform the decisions from there. The same thing will probably happen with the Moderna vaccine for people who got that a few weeks or a month or so from now. Moderna hasn't finished completing all of those studies and turning in that evidence. For people who got the J&J vaccine, and I'm on the J&J board, just want to make sure everybody knows that. That was approved a couple of months later, so it's a bit earlier in terms of the process of 6 months plus evidence on when a booster would have the most effect. So that's what people should expect, and I think we're going to know a lot more about the data on boosters when that advisory committee meeting takes place and when we have a chance for good open public discussion, which again, as I'm seeing the comments in the chat, is just really important for making sure the American public is informed and appreciates the evidence behind these government actions.
So, Mark, an important piece of this, as we've seen over the past 18 months in preparation for the vaccine rollout to begin with, is obviously quantity. And the president has said that the reason why they've targeted September 20th is they wanted to make sure they were ready with quantity in terms of the third vaccine. This decision about testing once a week, he had indicated that he may be using the Defense Production Act for testing kits. How are we in terms of being prepared as far as more significant testing going on, the requirement for testing?
Well, yeah, first, in terms of supply of vaccines, we're in very good shape. So unlike the case back in January, February, March, where there were a lot of people who wanted to get vaccinated and we're still ramping up the vaccine supply for all of the vaccines. This is something we track. If you go to our Duke Margolis website, you can get more information on this. We do have plenty of supply. We're now at a point where people can get vaccines in local pharmacies from their local healthcare provider and also employers. In many cases, including many of your employers, have set up collaborations with healthcare providers, local public health authorities to make it easy to get for their workers to get vaccines. So I'm not worried about supply here. There have been a lot of questions about whether we can provide similar kind of access to vaccines, the ones that really work here and have all this good evidence behind them, to the rest of the world, especially low and middle income countries where the rates of vaccination are much, much, much lower and where we're seeing more of these worrisome variants emerge that like the Delta variant that came from India and others that emerged from Peru and elsewhere. We really do need to treat this program globally. I do think we can do both and get most of the world vaccinated by next year. And again, we've got more information and evidence on that for people who want to follow up on our website. With respect to testing, there was a big lull in testing interest back in June and July when those case rates were lower. Now that we've got a much more contagious variant that, as you've heard, does lead to a higher rate of breakthrough cases with mild and asymptomatic infection, it is more important, especially in populations that are not fully vaccinated. Those individuals who aren't vaccinated are at least 60% more likely, or several times more likely than people who are not vaccinated to get an asymptomatic infection. They're also the ones who are at much higher risk, 25 times higher risk for being hospitalized with serious infections. So you can see why it's very important if you're bringing people back to work that you have some kind of way of detecting these outbreaks early. So we do regular testing at Duke. Many workplaces do, all sports leagues do, et cetera, et cetera. And the supply of tests is up above what it was. There are people who are having a bit of trouble getting access to those so-called antigen tests that people can use immediately. There's another type of testing, PCR tests and pooled PCR tests that are a bit more accurate. They have to be sent off to a lab in most cases. So that can take a day or longer to get back. There's strategies for using both approaches to help keep a workplace open and safe, especially in the presence of significant numbers of unvaccinated individuals. We've got a lot of data on that. And also, as you know, from our collaboration with CED, the COVID Collaborative has a lot of data on that as well.
Mark, I'm just going to actually ask a quick question from the audience, which is, who will pay for the testing kits under the president's mandate at the workplace?
So it's a really good question. For anybody who has symptoms, you can go get tested now at lots and lots of places, most pharmacies, et cetera, that easy to find. There are web resources that the federal government set up, that local governments have set up on testing in your area. That's going to be covered by insurance. It's required to be covered with no co-payments. For the workplace programs, there are assistance programs available in many states for schools, for settings where there may be limited resources. So Michigan, other states have set up programs like that with the kind of support that the federal government announced that yesterday. More of those kinds of testing resources will be available too. And so there are places to go to get help. It is something that for many, especially larger employers, this is something you need to think about as a cost of doing business with bringing your workers back to work. This is why if you're thinking about like total cost versus the benefits for your organization, it's important to also consider the vaccination approaches as we've said, and I'll just speak to the evidence, happy to speak to the evidence on this. Vaccination and vaccination requirements with exceptions for people who have health reasons for not getting vaccinated, disabilities, et cetera, with exceptions for religious reasons. Those are cases where testing may also help keep the workplace safe. That is the most effective way to get infection rates down among your workers and your employees. And the COVID collaborative efforts on this question is something. Go to COVID Collaborative. You'll see a lot of support based on the evidence from former Republican administration officials like me, Jerome Adams, Scott Gottlieb, people in the Trump administration, all supporting these kinds of actions by employers because they are really effective at reducing infections in the workplace and protecting the lives and the health of your workers from serious infections. On top of that, testing can really help with detecting problems early, and you should think about some of the costs that may be imposed by that. There are a lot of resources, again, available for thinking about those cost impacts.
Thanks, Mark. And if I could turn to Dr. Ko. if you could actually, if we could step back, the president said his mandates would take time to have full impact. Can you give us an overview as to where we are nationally with COVID infections and vaccines? Where do you see us for the remainder of 2021 and 2022? And I know it just happened yesterday, but can you factor in the president's mandates in terms of your projections?
Yes, thank you very much, first of all, Laurie, and for you and the CED for the kind invitation. It's a true honor to be included with the esteemed panel members. So let me first build off with what Dr. Hicks said, and let's think about the Delta wave, which roughly began around July 1st in this country. We've had 7 million cases, 40,000 deaths, and I think it's important to mention the caveat that there's been enormous variation in the burden of COVID during this Delta wave in different regions across the country. Just to give it an example of extremes, in Connecticut, where I'm situated, where we have 67% of our population fully vaccinated, we have roughly 3 to 5 deaths per day on average. And we compare that to Mississippi, where 40% of the population is fully vaccinated. They're suffering 40 deaths on average a day. And that really brings us back to reinforce, I think, the messages that I think, Commissioner Sebelius and Dr. Hicks said, is that the main determinant or driver during this Delta wave is the underlying vaccination coverage in regions within the US. I think the fortunate news is that in most regions, we're not experiencing exponential growth in cases, and that we may be reaching the peak, or in many, several regions, a decline. So I think that's perhaps the good news, and that parallels what's been seen in other countries that have suffered the Delta, suffered Delta waves. With respect to vaccination, we've had a drop off in vaccination rates, in the months of May and June, and with the Delta wave, there's been an increase. In July 1st, 55% of all Americans received a first dose. Now we're up to 63%. And so certainly there's been an influence of the risk and the fear, embedded with the Delta wave in terms of vaccinations. I think with respect to the forecasts of what's going to happen the rest of this year and early next year, I think if there's anything that we've learned during the pandemic, it's really humility. I think there were very few of us, and including myself, who would have predicted that we would be confronted with a pathogen that would double its transmissibility within a period of 1 year. And so we really need to be cautious about the kinds of projections, given the uncertainties on many different fronts, including vaccinations. My personal read is that, like many of the other countries, and we look at Israel, we look at UK, we look at India, we're going to be coming down off the curve, and for reasons that we really don't entirely understand. The question is how fast we're going to come down off that curve, and whether we're going to prevent a resurgence. And I think the drivers or the levers there are going to be the non-pharmaceutical interventions that we have in place in schools, such as face mask use, vaccinations, how fast we can ramp up vaccinations, and then working back to what we had, thinking about last year is, we across the country came down off the curve in last summer, but we had a large resurgence in the cold winter months. And that's certainly going to be a challenge and a potential impact. And that makes it ever more critical about this discussion on vaccinations. And that leads to the president's announcements. So we have 120 million Americans who haven't been vaccinated, 80 million who are eligible. And the key issue that's coming up, and I'm looking at the chat, is what's the impact of the hard mandates versus soft mandates? Much of the information, much of the evidence that really came off in support of soft rather than hard mandates really came from our experiences with influenza, which is a very different situation than what we're experiencing now with the pandemic. My own personal opinion is that I think that we're primed for hard mandates. We've seen them successful in institutional levels. We've seen this successful in other countries, and that the type of hard mandates that the president announced yesterday are what we need, much like what has been done in other countries in order to control their Delta waves. And that will certainly, decrease the burden that will be encumbered, particularly on the severe outcomes, hospitalizations and deaths. vaccination, does decrease the risk of infection, but it's not a transmission blocking vaccine. So we're not going to reach the magical herd immunity, threshold that will enable us to be completely free of transmission infection.
So if I could come back to Israel, because there is a question from our audience about Israel and the fact that they used Pfizer, 80% of the infections are in the vaccinated. And the question says that the data is also showing the boosters don't work, and can you explain? I'm not quite sure that's right. What is the data showing in terms of Israel and the boosters?
Yeah, so Laurie, I think you're right. In what the effectiveness of boosters, there just hasn't been enough time to really understand how they, if they're effective enough, or enough what we call follow-up time or observation time to come out with strong recommendations or policy on their effectiveness. But working backwards a little bit, I think Israel is a good example of kind of the conundrum that we're facing in how we're thinking about how COVID will play out in the future months, and particularly the winter. So you have two processes that are very difficult to tease out. One is the potential waning immunity that's conferred by the vaccine, and the other is the innate resistance of variants such as the Delta to vaccine effectiveness. And those two things are what many epidemiologists, including myself, are trying to grapple with, how to tease out those two different types of processes. And I think the bottom line, if you go back to Israel, is that you can say proverbially they dodged a bullet. They are having cases, but deaths are quite low, and very much similar to what we're seeing in highly vaccinated states in the United States, here in the American.
Dr. Hisks, there's also a question about masks and the science about the efficacy of masks, and asking if there's a report that actually helps substantiate the science about using masks. Can you help us with that question?
Yes, absolutely. So I think this pandemic has given us a lot of opportunity to learn about how we can use non-pharmaceutical interventions to prevent transmission. And what we've learned is that masks are really effective for source control. And what does that mean? That means the individual who is infected, if they are wearing a mask, they are much less likely to infect the others around them. And so here's the data. We see that if both the individual who's infected and the individuals who are in contact with the infected individual are in masks, they are much less likely to get sick with COVID. If the individual who is a contact of the infected persons, if those are the individuals wearing the mask, but the person who's infected is not wearing the mask, that's less effective than if the individual who is infected is wearing that mask. So generally speaking, if an individual who is ill, or they may not even know they're ill because a lot of transmission happens before symptoms develop. So especially if someone has been recently exposed to someone with COVID-19, if they wear a mask consistently and wear it appropriately, then transmission is much less likely to occur. We've started to see some really nice data. There was a study that was actually published from a Bangladesh study this past week that showed that in communities where masks were used, there was a much lower likelihood of symptomatic COVID. And they did actually blood tests to check for whether these individuals had evidence of infection. And so it's something that's so very simple, but quite effective. And what we're recommending is that this is one of multiple strategies. And the point I want to make is, just like vaccine is not 100% effective, neither is a mask, neither is ventilation. And so it is putting all of these things together that maximize prevention. If there is interest in looking specifically at the data available en masse. CDC actually has a science brief on our website, and I can drop that into the chat. There's the science brief on masking. We're actually in the process of updating it because there's a lot of new data to support it. And what I would say is my son was in school all last year with a mask. He's 9 years old, didn't complain about it once, and didn't actually get a single respiratory virus the entire time he was in school last year in masks. So masks do work, and it's just a matter of identifying how, one, we can improve comfort and improve fit, and I think making sure that this is part of social norm.
Thank you. Secretary Sebelius, there are a couple of questions here about the actual implementation of the president's mandates, and one is how long will it take for OSHA to actually write the rules that are necessary regarding the mandates, and will it cover workers who work remote, so everyone who's employed, or only those who show up in the office? And a third piece of this is concerns have been raised that this may be the president's announcements may be too little, too late, and may actually exacerbate the already tight labor markets, particularly in terms of healthcare workers. So a bundle there for you.
Well, I think the first two are the easiest to deal with. I don't know. OSHA will be directed to work as quickly as possible, but they will take input. They'll look at other existing standards that are in place. I mean, they'll try to move as rapidly as possible, but when exactly they will come out with the rules, I just can't tell you. I think they clearly have directive from the president to move expeditiously. In terms of remote working, again, that will be part of the rules. My sense is that this will deal primarily with people who are gathering in a workplace. That's the concern, and that will be the OSHA view, I think, is safety in a workplace. So whether or not remote workers are required to come into a workplace periodically, then they may fall under it. I think that will all be part of the rulemaking. And, certainly there are already employers who have mandates in place, who are giving accommodation to people with religious and medical exemptions, who are finding ways to accommodate folks. So this is not like they're creating out of whole cloth new entities, because these mandates have been voluntarily put in place by a number of private employers. And I think they'll take that into consideration very quickly as they look at the future. The second part, Lori, dealt with OSHA, and then
the impact of the president's decision.
Too little, too late.
Yeah, and exacerbating the labor market.
I have to tell you, we live in a crazy world right now. And, the outcry that has accompanied the president's announcement, on one hand, it seems to be the world is coming to an end. And now there's going to be, I think, a similar outcry by people saying, why didn't you do this sooner? And where have you been? And what's going on? I don't think we can underestimate what has happened in this country, which is, I think, incredibly dangerous about the future, which is that there always has been a political debate about science and power from the government versus power for the individual. That has been a tension and a debate, and that is part of the American culture and will continue to be. What we haven't seen before this particular outbreak is a partisan overlay to that discussion, and a partisan litmus test about whether or not you are going to follow science. And I think we'll see that playing out again in this instant. And that, I think, is pretty dangerous. I live in a state where we have a governor of the Democratic Party who has put forward various kinds of health issues, mask mandates, other to be overruled immediately by the legislature. And the back and forth is not only incredibly confusing for people, but very frightening for lots of folks who have no idea what rules to follow. So in some ways, the president, again, has put out a national policy, a national guideline about vaccinations, again, emphasizing that we know that is the very best way to end and deal with this COVID virus, the Delta variant and others. So he's trying to put forward a national message, hoping that, again, that will be mirrored by people up and down the line, and using every tool he has, I think, as a federal employer, as a from the bully pulpit, from the workplace safety standards, to try and dial up the public and private sector to get vaccinated.
Mark, two questions to you. One a little bit more broadly in terms of what challenges do you see the business community facing? You've been very involved with the business community and the COVID collaborative. What challenges do you see them facing in terms of the president's announcement yesterday as far as legality of his decisions? And then a more specific question about whether surviving COVID-19 and the immunity that one would get from surviving COVID-19, would that be enough to demonstrate immunity equivalent to a vaccine in the workplace?
Okay, so two different questions. On the first, I think businesses are on the front line here, and that's why all of you who are joining, and I know there are a lot of strong opinions, and tell from the chat on these issues, this is a really important discussion to have. As Secretary Sebelius said, it is going to be a while before that OSHA rule with the mandate for vaccines or testing. Remember, it's not just a mandate for vaccines, the vaccines or testing gets implemented. And after that, assuming it has a effect, it's 2 doses of vaccine. It's going to be a while later before those steps start to have an impact on bringing cases down. What has had an impact in many businesses already is the actions by businesses to take a set of steps. The most effective one, again, is some kind of vaccine requirement to be at work, especially if you're around other people where you are impacting their health and their productivity and liberty at work. Those steps do work, and there are many CED companies that have taken that step. It is one that involves hopefully some discussion with your employees. They have a high degree of trust in you, and there are a lot of employers that have had those discussions, involved local experts, trusted individuals, healthcare experts, and have successfully implemented very high rates of vaccination. So that's what's going to make a difference in the shorter term before that federal mandate, which is 75 days process after it's finalized, before that OSHA rule gets finalized. That one is going to be challenged, it already has been by the Republican National Committee, and the president's action does make this more political, but the actions by employers don't have to be that way. Those involve your employees directly, and those steps, including vaccination, masking when people are close together, testing on a regular basis, steps to improve airflow or reduce spread of cases in the workplace, especially now while COVID is so prevalent. If we get vaccination rates up, if we take these other steps, the case rates are going to come way down. We're not going to need masks. We're going to be more like the June situation that we saw before, but we are way far away from that now. So there are some very important steps that employers can take. That COVID collaborative website is one that describes these steps that many employers are implementing. They've done it on a private sector basis. It's had a positive impact on their workplace and on economic output as well. So I hope those are things that you all will think about, separate and apart from the political debate and the regulatory process that is going to follow from the president's announcements. With respect to immunity, no question, having COVID gives you some important immunity to further infection, but we have seen a lot of breakthrough cases in people who have been previously infected with the earlier version, the original version, or the alpha variant. That's a couple of variants ago. The ones we have now are much more contagious, and there are others that are emerging. And what we have seen is that for many of those individuals, just one dose rather than two can give them a significant boost in immunity. It's like that, like I said, it's the idea before of having an initial shot and then maybe having a booster shot later. That can give them a significant boost in immunity. And so that's, I think, where the scientific evidence and the CDC recommendations, the other medical recommendations are now for people who had a prior infection.
Thanks, Mark. And Dr. Hicks, turning to children, there were a number of questions about children. The president clearly is very concerned about children and has mandated a vaccine for 300,000 educators in the Head Start program. I know the CDC has recently released 2 reports on this. So can you help us out in terms of the implications of the Delta variant on children, especially children under 12? Why is 12 the magic number in terms of vaccinations? And what are the implications for the overall infection rate in the general population with children returning to school?
So as I mentioned, I'm a mom, so I'm thinking about this on a daily basis. And I want to emphasize that there's been a dialogue that children do not experience severe infections. But I want to dispel that myth right here, right now. It's true that compared to adults or compared to individuals who are older and have underlying conditions, kids have fewer episodes of severe disease. However, nearly 500 kids have died from COVID-19 in this country, and I find that unacceptably high. I just can't imagine being a parent and having your child die from COVID-19 or anything else for that matter. But this is something that we can mitigate. We can work together to prevent kids from getting exposed to COVID-19. So I really think we need to do that. And it's the adults that really need to come together to make sure that that's happening. So I just want to put into perspective what's happened over the summertime. Last year, the case rates were highest among older adults and people with underlying conditions. Now they're highest among kids. We have seen an incredible increase in the number of children who are acquiring COVID-19, and our emergency departments and children's hospitals are full of kids who have COVID-19. And I want to also mention that about 1 in 5 kids who are admitted to the hospital end up in an intensive care unit. So again, emphasizing, there are a lot of folks out there saying this is not severe in kids. That is not true. Kids can die from this. And even if the child is in the ICU and makes it out alive, thankfully, these individuals can have long-term consequences. So we need to be real about what we're seeing in terms of disease in children. So in the states where there are higher vaccination rates, so the states where there are much higher vaccination rates have 4-fold lower rates of hospitalizations among children compared to the states with the lowest vaccination rates. I think right there that's very telling. And we really need to be thinking about, okay, well, what does this mean? And so when the question comes up about whether sending kids back to school actually creates the problem in terms of community transmission, in my opinion, it's the other way around. If community transmission is high, kids are going to be at risk. And that is actually absolutely exactly what we're seeing right now. And in terms of why we're focused on the under 12 population, well, I think Most of you know that the under 12 population is a group that cannot be vaccinated yet, my son included. And the reason why is because studies need to be done to identify the proper dose and make sure that the safety data are there to support the risk and benefit analyses that we need to decide whether and when and how much vaccine to give to kids under the age of 12. Those studies are being conducted now. And I know there's a lot of interest from parents who want to know when vaccines will be ready for the under 12 population. Studies are ongoing. I'm hoping and anticipating vaccines will be available for the under 12 population later this year, maybe early 2022. But again, really start to think about what can we do in the meantime to protect the under 12 population. And it's all the things that all of my colleagues have been talking about on this panel. It's masking, physical distancing, making sure the communities are vaccinated, screening, testing, ventilation, hand washing, and respiratory etiquette, staying home when you're sick. And so all of these things are going to continue to be important as we work to protect our kids. And one last comment, it's really important for our kids to stay in school. We are contemplating new methods of getting to kids and reaching kids through virtual education so that kids don't get left behind when they can't be in school. But to the extent that it's possible, we really want kids to be in school. I'll stop there.
Well, thank you. And Dr. Ko, there, as you can see in the Q&A box, there are a number of questions on other variants. And, you know, the Mu variant has been receiving a little bit of attention lately, and it's been listed by WHO as a variant of interest. How long will it take to get the data on these new variants so we can determine the efficacy of the vaccines against them? And projecting out if both in the United States and globally, and as you know, we all know the COVID and the variants have come from overseas. What's the timeline that you could project of when you think a variant might evolve that will not be, the vaccines will not be efficacious against?
Well, thank you very much, Lori, for that question. Let me just make a first comment on Mu. So the Mu mutation, the Mu variant, which emerged in Colombia, was first identified in Colombia and now has spread to many places. For reasons, you know, I guess the good news is for reasons that we don't understand, you know, this is a mutant that has, this is a variant that has mutations which potentially may compromise the effectiveness of the vaccine and be what we call a vaccine escape mutant. For reasons that we don't understand, it hasn't outcompeted Delta, and that's kind of the good news on that. So getting to your question about how long will it take to get, you know, enough data so that, you know, and evidence on these variants once they're identified, and, you know, so that we can mount effective responses. Let's go, you know, there's several cautionary tales, and let's go back to the Delta variant. So that Delta variant caused a devastating emerged in India, caused a devastating epidemic. You know, you know, that peaked in last March, April, and May of this year, and then spread globally throughout the world. And we've seen this story come out many times. That we've seen the Beta variant from South Africa, the Gamma variant from Brazil, the Lambda from Peru. All of these are variants of concerns, or variants of interest. You know, of course, the Alpha variant from the UK. And I think the bottom line is that we're going to have variants emerge in places where we have uncontrolled transmission, where the virus is replicating. You create large panel of mutations, and you have selective pressure to whether it's from naturally acquired immunity to reinfection, from from getting COVID or from vaccines. And so the bottom line is that these variants are going to emerge in places of, you know, globally with uncontrolled transmission. And many of these places are going to be in the poorest parts of our world. And I think Delta really, illustrates that point very well. So in order for us to really develop timely responses and get the evidence, as your question had posed, we need to invest in building capacity in developing countries throughout the world, places where vaccinations have not occurred at levels. I'm thinking about Southeast Asia, South Asia, parts of Africa, parts of the Americas. And until we do that, first of all, we won't be controlling the pandemic. But second of all, we won't be getting that 4 or 5 or 6 month lead time that we need to in order to make best decisions for our own population here in the United States.
And there's a question about herd immunity and what role herd immunity without vaccines. Is it possible to reach that herd immunity with COVID and the variants?
Yeah, I'll draw upon Dr. McClellan's comments about what natural infection does, but also vaccine-mediated immunity. So we know natural infection, as well as vaccines, are giving fairly high protection against severe outcomes, things that we care about, like hospitalizations and deaths and so forth. Immunity from both mechanisms are not giving us the desired high enough infection effectiveness against infection and transmission. These aren't transmission blocking vaccines, for example, as we have it with measles. And that's where the conundrum lies with herd immunity. So we won't, because a person who's vaccinated can get infected and potentially infect a person who's either vaccinated or unvaccinated, where it's somewhat illusory that we're going to reach herd immunity. On the other hand, and that said, that doesn't mean that there is a protective effect given by infection, and it's probably higher than naturally acquired, natural infection. But there's probably immunity conferred by vaccines, which will dampen that, which will slow the transmission, will decrease vaccination. We've certainly seen this here in the United States. And getting back to your point about, whether natural infection, really protects us from transmission and all those, the bad outcomes from COVID. I've been working in Brazil for the last 30 years and had just returned from there. And, that's a good case example where many people were infected during the first wave of COVID. We had a Gamma variant emergence. 300 Brazilians have died in the last 6 months. And many of those, good number of those were reinfections. So that really goes back to the point that Dr. McClellan said about the importance of vaccines, in giving vaccines in people who've been previously infected.
Secretary Sebelius, we have 1 minute left, and I'd like to turn to you for your wisdom and advice. You were governor of Kansas or Secretary of Health and Human Services during SARS, MERS, Ebola. What is your closing advice in terms of how to defeat this pandemic? And most importantly, this isn't going to be the last pandemic, according to most of the scientists evaluating what is happening globally. How do we prepare for the next? What's the most important priority?
Well, I think getting out of this is vaccination and using all the other techniques of mitigation as we get the country fully vaccinated. We have the luxury of having free available vaccine, and we need to take advantage of it. Next, we do serious after action reports, but we know a couple of things. We know that the public health agencies throughout this country need to be rebuilt. And we have to pay some additional attention to efforts at the state and local level, because that's where things begin to happen, and there isn't coordination. We know that we need to analyze stockpiles and what needs to be essential in the United States. We did some things after H1N1 about increasing vaccine manufacturing capacity that have been enormously helpful, but we need to look at all those streams. And I think we need to, again, re-engage dramatically with the global community and adopt the global policy of a One Health initiative, which really looks very carefully not just at the human conditions, but at the animal conditions, because what we know is that pandemics and other diseases are often transferred back and forth. And, whether it's antimicrobial resistance that we know we're facing right now, or other things that are going to come, really up our game in terms of scientific sharing, investigation, and epidemiology.
So on behalf of the conference board, the Committee for Economic Development, I would like to sincerely thank all of our panelists, our distinguished panelists today, and all of our participants, and the importance of your questions in the Q&A box. And so thank you all for attending the town hall. And again, a special thank you to our distinguished panelists for helping us trying to understand where we are now and where we go from here, and how do we get out of this crisis regarding COVID-19 and the Delta variant. So thank you very much.